All right, so antibiotics. I hope you got some caffeine because antibiotics are probably the toughest section of this lecture because antibiotics will try to make as much sense as possible because otherwise there's a list of things to memorize. So we're going to try to categorize the antibiotics in different little things. Like we said, like some things affect gram negatives, some things affect gram positives, some things affect anaerobes. So we're going to kind of, to pull back your microbiology. That's what microbiology is a prerequisite for this course because you have to know all this stuff. So, how much of you remember all your micro from 1 to 5 years ago, right? So I think they still have a class in session right now. Yeah, he's still in session. So we can go over there. We can have him zoom in and teach us about micro. All right, but you have to know your different pathogens, right? And also what type of pathogen they are. If they're anaerobic or aerobic, if they are gram positive, gram negative, it's going to help. But we're gonna reiterate that for you because I know not everybody remembers their micro. Okay. Before we get into that, just some general things about antibiotics. Right. So we get cultures before we give them. That's the ideal thing. That happens 9 times out of 10. Sometimes there are severe situations where you have to flip it up, but the right answer on the test is give antibiotics before or after cultures. So remember that question can be phrased either way, right? So the cultures are done before antibiotics, and the antibiotics are done after cultures, right? All right. So if you do blood cultures, usually it's 2, right? Because 3 is actually best. It's like only like 80% accurate if you get 2. If you get 3, you're up to like 97%, right? Because you can miss it. So if you do 3 cultures, you're going to get the bacteria to grow up maybe on the 3rd culture. Okay, do about 10 minutes apart. Usually we do it peripherally. We don't do it through the central lines. It's supposed to be peripheral. And then empiric antibiotics. So we give something that's empiric. What does empiric mean? No, empiric means non-specialized. It means you think you know what it is, so you're going to give something just in case, right? Like you think your gas tank's going to be empty, so you're just going to fill it up with gas, right? So that's an empiric gas exchange. Like, I don't know. Anyways, you have a bacteria that affects the lungs and causes pneumonia, like strep pneumoniae. So usually we're going to give antibiotics that attack strep pneumoniae, right? We're going to give empiric antibiotics. If we don't know what it is, we're going to give something that covers all the things, right? Gram positives, gram negatives, anaerobes. Pseudomonas is very, very potent and virulent. So we're going to cover all those things, right? So those are our broad spectrum antibiotics that are empiric. But are we going to continue all 3 or 4 of those antibiotics for forever until they're discharged? No, we have to narrow the antibiotics. So we did the cultures and they come back. How long does it take for a culture to come back? Take about 2 days. On day 1, they can tell you if it's gram positive, gram negative. They can tell you if it looks like cocci or rods or spirochetes. They can tell you that on day 1, but they're not going to be able to identify it until day 2. All right. So definitely by day 2, you want to make sure you're trying to narrow the antibiotics, and we get on the culture report. It says, hey, you have this bacteria. But also on that same report, it tells you a sensitivity. So it looks like one of these readouts right here. So it tells you what antibiotics work best, right? So what antibiotic is effective for this strep pneumoniae? Is it this vancomycin, which is like pulling out like a shotgun, or can it be this simple ampicillin, which is like a handgun or a knife, I don't know, right? So we want to use something that is going to have the best efficacy, right? Is to be the best one for them. So they on that report, it has what's called a MIC or a MIC, M-I-C, and that stands for the minimum inhibitory concentration, right? So that's the minimum amount of antibiotics you need to kill it, right? So if I only need 1 MIC to kill that bug, I should use that one compared to a MIC of 4 or 12 or 24, right? If it takes 24 of that antibiotic to kill that bacteria, that's not good, right? So you can see here vaguely, see the little circle there, right? Compared to this one over here. This one over here took a lot of, that bacteria grew a lot more compared to the other one. So this took just a little bit of antibiotic and that bacteria did not grow, right? So that would be a better one to use. So you can see meropenem right there is less than 1, right? Whereas ceftriaxone is greater than 32. So which one's the better antibiotic? Someone wouldn't be on both of those technically, but if they were on both of those, right? Which one should they change it to? change to the meropenem, which is less than 1. That means it took just one little piece of meropenem to kill the bacteria, versus it took 32 pieces of ceftriaxone to kill the bacteria, right? So that is, the concentrations are different units, but I'm just saying that's kind of how you want to look at it, right? So the one down there, the bottom middle, which one's the best antibiotic to use? So vancomycin has a what? Less than 0.5, right? That's great. It took only a little 0.5 of vanco to kill the bacteria, right? Whereas it took 32 of rifampin. We don't really give rifampin nowadays, but like tetracycline. It took 16 of those, what did I say? I can't remember the numbers. So it took that much to kill that bacteria. So it's better to use, we want to narrow it to a specific antibiotic if we need to, right? And also this is also in a sterile lab. So sometimes certain antibiotics don't actually work on like pneumonias, right? They can't cross into the surfactant will neutralize it, or they don't cross into the blood-brain barrier. Like we did at LP, at lumbar puncture, we pulled out CSF, say, hey, they got Neisseria meningitis. So let's give vanco, but vanco doesn't actually translate across the blood-brain barrier as well as you'd think. We have to give another one of these that are good. Right? So there's more nuance to that, and we're not going to test you on that. I'm just let you know that this is like, you're in clinic, you're like super frustrated, like, why don't they start this? This one's the best one, right? So it's like, well, it's because that one actually doesn't work on the CNS, right? So positive blood cultures, right? They come back and they tell you what is growing, right? If you do get staph on a blood culture, or strep for that matter, you need to have an echo done. That's why it's in red, because that's going to be a sign of endocarditis. Staph and strep like to hang out on the valves. They might not have it now, but they are high risk for that to happen. So you usually get an echocardiogram if the culture reports show gram-positive, show staph or strep. Okay. There can be something called contamination. So when they draw the culture, it was contaminated, and that's just, the lab will tell you also that it's contaminant because it has a bacteria that doesn't really cause disease. It's just that bacteria is there because it was on the skin, right? So what else? So sensitivity will tell you which antibiotic's the best, right? We want to do that. We want to go towards the antibiotics not going to cause resistant, because we have things that are resistant to vancomycin. So we might want to keep them on medication that is not as great, right? But it will cause less resistance in the long run for the community. Okay. Well, good point. So sensitivity is what works. R means what does not work. So your patient should never be on antibiotic that says R. Your patient might be on an S that's not as great as the other S, but they should never be on an R, because that means that it's resistant. All right, that means it grew right through it. Like this one over here, probably, I don't have to see exactly what it looks like up close, but it just grew right through it. The antibiotic did nothing, right? It's resistant. All right, so what else? So higher MIC, right? Is good or bad? Is bad, right? The bacteria is more resistant. Okay. All right, so general principles for antibiotics, and this makes you what's called an antibiotic steward. All right, so you've all been knighted as antibiotic stewards, right? So antibiotic steward means you are doing the best thing for the community. You are making sure that antibiotics don't get misused, right? Like they were back in the day. So we just gave a whole bunch of antibiotics, and hopefully they got over it, and we didn't check, right? So now we have all these guidelines. We have to make sure we are doing the right thing for antibiotic-wise, right? So one, you got to get cultures, because otherwise your antibiotics are going to destroy the bacteria in the cultures, and then you're not going to know what it is. You're going to be on that antibiotic for like 5 to 7 days, and it might have been the wrong one the whole time, right? So antibiotic therapy should continue. Like for instance, you get something back, you're like, whoa, shoot, that's a 0.5, and the one I'm on is a 1. You don't want to surf around different antibiotics, right? You want to keep the one that's working, and we look at them clinically. They're looking great. They were on 7 liters, now they're on 5 liters, right? Now they're on 3 liters. For the pneumonia, we don't need to switch them over to a heavy-duty antibiotic. The antibiotic's doing its job, right? Also, we want to DC antibiotics in a relatively straightforward amount of time. There's a lot of research out there. You don't have to know the numbers. I'm just saying different antibiotics have different durations of therapy, right? Traditionally, everything's like 5 to 7 days. That's how long antibiotics usually are. But certain things don't have a lot of vascular supply, or don't have a lot, are very resistant, such as like endocarditis, for instance, needs antibiotics for how long? It's like up to 6 weeks, right? Osteomyelitis, up to usually like 4 weeks or so. So these things require a lot longer duration of therapy. Okay.
Do you have to cycle them if they're growing resistant.
So if they're resistant, you definitely need to switch it out. The other reason we might switch it is if they're not getting better, right? They went from 7 liters to 10 liters to non-rebreather to BiPAP to intubation. Like we got to escalate it. We got to escalate the antibiotics. We got to change them up to something else. And if we have cultures, we can look at it and say, well, shoot, they were on the ceftriaxone up there that was greater than 32. Of course, they didn't do great, right? So it's the clinical picture, but it's also the labs, right? And then the other piece is involving ID. Who's ID? Infectious disease. So the infectious disease doctor, they're actually the least paid doctor, but they have to know all this stuff, and it's crazy amount of stuff they have to know. But they are required to. You need to involve them when they have a complicated patient, right? They have HIV. That's probably a patient. When we get to HIV, you're like, yeah, we need an ID doctor because there's all kinds of combinations of drugs. Someone has Hep B, you could get them involved. They know that stuff, like all the different combinations of drugs and such, right? Someone has TB, someone's not getting better. If they're on a really complicated situation, you got a cirrhotic with this and that and the other thing. You got all kinds of, have 2 infections at once. You definitely want the ID doctor involved, right? And of course, as you know, as between antibiotic steward, you don't want to use antibiotics because you didn't wash your hands, right? So you're washing your hands, you're doing the right isolation practices, right? That's the goal, right? So, wash hands, is the isolation appropriate? So one of the things for your test you have to know is what, if they have this bacteria, especially like an MDRO, what isolation would I do, right? If they have TB, what isolation do you use? What do you think it is?
TB is airborne.
TB is airborne, right? Like MRSA sputum is droplet, MRSA nares is contact, right? So there's different things. VRE is contact, for instance, right? And of course, to be an antibiotic steward and to prevent infection in the first place, you got to take out the plastic, right? Take out the lines, tubes, and drains if they don't need it anymore. If it's still draining a lot of stuff, that's great. You're taking out the source of infection, right? But if it's not draining anything, so if it's been 3 days, like you left on Friday, you come back Thursday clinical and they still have that JP drain, that's a problem, right? It should, unless that JP drain is draining a whole bunch of stuff, that's probably another problem. They probably have a fistula. But anyways, there's things you want to take out plastic if you can. Peripheral IVs don't get infected. They'll scare you and say, oh, you got to switch every 3 days to change sites, and it never happens. Yeah.
Now, do you want to change it out, like let's say a uric or a JP drain? Do you want to change that out after a while?
If JP's not draining, you would take it out.
Right,
but if it's there and it's draining, no, not really. Not unless it's like you really like it's like red around the JP site, then you know that maybe the JP is the problem. But yeah, that's a unique situation. Yeah. Okay. So that's how you be an antibiotic steward. You do the cultures. You make sure that the antibiotics are correct. You don't go back and forth antibiotics. You use the best antibiotic for the patient. Okay. So then antibiotics. So how are we going to tackle this? Because there's a bunch of them, right? So this looks at the different types of antibiotics, right? So we have gram positives. Gram positives are purple. So I've color-coded this. I spent many hours trying to color-code this to make it make sense. So whenever you see something is gram-positive, it's usually purple, unless I forgot, right? So you have gram-positive bacteria. You have gram-negative bacteria. And if you do a gram stain, that is going to be gram-negative, right? And then we have anaerobes. So imagine like your blue and cyanotic, right? So you have anaerobes out there, right? And sometimes you can be affected by anaerobes, right? So you have a bacteria that's growing in an area of the body that does not have oxygen. Where is that? Where in your body has no oxygen? What right now is getting no oxygen supply? Where in the genitourinary? Bladder. Yeah, bladder has the walls of the bladder get a blood supply, but the bladder itself that's filled with urine does not have a blood supply. So anaerobes grow in the bladder, right? Where else do anaerobes grow? The colon, right? Inside the colon, right? The lumen, right? You don't have a blood supply, right? And like, get some oxygen, right? Right? That's not a thing, right? So the inside of the lumen could have bacteria in it, so we can give anaerobes to combat that, right? And then where else?
Cavities?
Yeah, other cavities, right? So what other cavities?
Sinus, pleural.
So pleural cavities have have oxygen, right? But if they have an abscess there, they have like what's called a loculation, where it's like walled off, and that's what bacteria usually do. They like put little fibrin walls around them so they can then percolate, right? So yeah, if they have like an empyema there, if they have like a fluid collection or a pus collection, that's an area that does not have oxygen, right? So we have to give it an antibiotic that covers anaerobes in that case. So a GI, a GU situation, or they have an abscess, like they have an abscess in the skin as well, right? That abscess does not get a blood supply. If it had a blood supply, it'd be called a tumor, right? If it has no blood supply and it's purulent, that is an abscess, right? That is anaerobic and it's an abscess, all right? And then here in the rainbow colors are atypicals. So atypicals, you don't usually cover for immediately because they are atypical, but usually if a patient's not getting better, we'll start on antibiotics for atypicals, or certain disease processes like COPD, they're at high risk for atypicals. Also for pneumonias, like mycobacterium pneumonias, Legionella pneumonias, those kind of pneumonias those bugs are atypical. So we have to give them atypical antibiotics, right? Something like COPD, they're high risk for pneumonia, and pneumonia can be strep pneumoniae, which is what? Gram-positive, gram-negative. What is strep pneumoniae? That's gram-positive, right? But otherwise, you have Haemophilus is gram-negative, but you also have what we say, mycobacterium, and that is a common reoccurrence. So usually COPDers go home for life with azithromycin. Azithromycin covers atypicals, right? It's going to be there to cover that, so they don't get readmitted with their COPD because they had a pneumonia, right? But if someone comes in from the outside with a community-acquired pneumonia or even a hospital-acquired pneumonia, we're going to hit them up to cover the gram-positive, gram-negatives, and atypicals because we know those bacteria are indicated in pneumonias, right? So you want to cover the most common bacteria for a specific infection. And we broke those down at the end of this antibiotic section. We're going to break it down again. You have don't know, right? You're going to cover everything, right? So we're going to cover all these things, right? Or they have a skin and soft tissue infection, right? So like MRSA can be there, or you could have a staph infection, right? A MISA, a methicillin-sensitive Staph aureus, or a MRSA, which is resistant to penicillins, right? So a skin and soft tissue infection, you can have pneumonias, you can have UTIs, abdominal infections, or you can have a don't know, and we got to cover everything, right? So these are the common bacteria. So in yellow, as you'll see highlighted throughout, are going to be MDROs. So MDROs are yellow. Usually MRSA is the #1 thing we cover, right? MRSA is very, very popular, right? It's first place. It's the most common MDRO, and it can cause skin infections, it can cause pneumonias, it can cause UTIs, and it can cause abdominal sepsis, and it can cause a widespread inflammation, widespread sepsis. So we should always cover for it if they are at risk, right? Or if they are, or if they're really, really sick and going like to the ICU, we got to cover for MRSA, right? And spoiler, the antibiotic for MRSA is Vanco, right? So everybody's usually on Vanco for the first 2 days because it could be MRSA, right? If you guys are in PCU or in tele or ICU, you'll definitely see Vanco a lot because it's going to be given for someone that has possible MRSA, right? Because the other antibiotics they are on also cover gram-positive, gram-negatives, but they don't cover MRSA. We have that specific antibiotic just to hit the MRSA because it can cause like a necrotizing pneumonia, which is not good. That's hard to recover from, right? It can cause like a line infection, eclampsia, and it can get to the valves. It causes endocarditis. It's a really, really bad situation. Okay, so we want to cover gram-positive, gram-negatives. So we have those are called broad spectrum. If they cover more than one class, they're broad spectrum antibiotics. There are some narrow spectrums, like there's some antibiotics that are great for gram-negative bacteria, right? And also we want to cover what's called Pseudomonas, right? So MRSA is methicillin-resistant Staph aureus, which is very, very hard to treat, and Pseudomonas is very, very hard to treat. And usually those are patients that have been inside the hospital system. So they have like a hospital-acquired UTI or a hospital-acquired pneumonia, or they are going to the ICU, or they're really, really sick and a lot of oxygen. They're going to be get Pseudomonas, what's called Pseudomonas coverage, right? This makes sense. These are different categories, right? So we're going to cover for these different things, right? And then atypicals are usually last to think about. All right, I gotta highlight that one, make it colorful. Anyways, Spirochetes, we're not going to really worry about, but mycobacteria, I just put it there because we have Mycobacterium tuberculosis, not mycoplasma. Mycoplasma doesn't have a cell wall, right? And when you have a cell wall, that's when you can actually stain it, right? And it stains either red or purple, which is gram-positive or gram-negative, right? But mycoplasma, right, here's a gram-negative over here, here's a gram-positive there. Mycoplasma have no cell wall. So when we have bacteria, like everybody in clinic says, oh, this inhibits the cell wall synthesis, right? Vancomycin inhibits the cell wall synthesis. My penicillin inhibits the cell wall synthesis. Well, if you have no cell wall, penicillin's not going to work. Vanco's not going to work, okay? But then the last piece, I just want to point out Mycobacterium tuberculosis because we have to talk about TB. Right, that's one of the last things we'll talk about is how we give antibiotics for TB, and those antibiotics are just specific for TB. Usually none of those drugs we give for other things. Good? All right, so gram-positive, gram-negatives are usually pretty standard. That's what we're going to cover. Pretty much if someone comes with an infection to an urgent care or to a doctor's office, you're going to give them gram-positive, gram-negative coverage usually. And then we might cover atypicals, especially if they're like a pneumonia. But and then we have to make sure it's the right antibiotic, right? And then also depends on where you live, because in the Antelope Valley, we have different resistances compared to somewhere like in Ventura Beach, right? There's different, those are called antibiograms. So it's like what antibiotic is great for this area versus that area. So that adds another layer of complexity to this, okay? That's not something you're going to have to know. It's like, oh yeah, and Zosyn works 46% of the time up here. That's not something you have to know. We want you to know that Zosyn is a strong antibiotic, and it covers these things, and it is for these disease processes, for these types of infections.
That's what the ID doctors specialize in.
The ID doctor is not going to get in until like they're not getting better.
Gotcha. Right?
So usually we're going to start Zosyn and Vanco pretty much in everybody, because Zosyn, just a spoiler, covers gram-positives, gram-negatives, anaerobes, and Pseudomonas. Right? And then all we're missing is MRSA. And who covers MRSA? Vanco, right? So everybody's on Vanco and Zosyn and Vanco, right? It's guaranteed they're on it, okay? And Zosyn is a what? It's piperacillin, tazobactam, so piperacillin, it's a penicillin. So if someone's penicillin allergic, they're gonna be on cefepime instead. But so it's either cefepime and Vanco or Zosyn and Vanco. All right, so we're an antibiotic steward. We're going to make sure we are narrowing this because we're going to cover all the stuff, and we might cover it with some really heavy hitters that are going to annihilate the bacteria, right? And sometimes we annihilate the good bacteria, and what do we get then?
Diarrhea.
You get C. diff diarrhea, right? Or C. diff associated diarrhea, which is CDAD, right? Or C. diff infection, CDI. Okay, so antibiotics, I mean, if you have to guess in clinical, just say it works on the cell wall. You're probably going to be right. Right, like 80% of the time. Oh, I think it works on the cell wall, inhibits cell wall synthesis, right? Yeah, a lot of them do, right? And it's because there's a huge category of antibiotics called beta-lactams, right? There's 4 beta-lactam categories, right? Penicillins were the first ones discovered, and then we graduated to cephalosporins, and then we graduated to carbapenems, right? And we don't really use monobactams that much anymore, but those are the 3 big ones: penicillins, cephalosporins, and carbapenems, right? And we'll talk about how the suffixes, because you would think it'd be nice that every class of antibiotic would have its own suffix, but it doesn't. Like everything ends in mycin. It's like, guys, you could have made them line up at least, right? Only a few of them do. Like cephalosporins, they all have ceph in it somewhere. It might be in the middle, but it's everywhere, right? Like ceph, oh, I found you, ceph, there you are. And sometimes they spell it different, like CEPH, right? So it's like, so you got, it's like, oh shoot, I can't figure it out. But no, that's the nice one. Every penicillin ends with cillin, which is cool, right? But pretty much after that, or actually penems all end in penem. But after that, like nothing lines up, all right? All right, so it works in the cell wall. So we can disrupt the cell wall from being made. So the cell wall is either gram-positive or gram-negative, right? Remember your micro, one has 2 layers, one has 1, but that's not what we're worried about. We're just worried that it's going to stop the cell wall from being built. And you can either annihilate the cell wall or you can stop the cell wall from being built. Either one is effective. They used to think, well, I'd rather destroy it, right? That's called bactericidal, right, versus bacteriostatic antibiotics, and they're both effective. They're both fine to use, right? Vancomycin is its own category, but it does work on the cell wall. It's going to inhibit cell wall synthesis, right? We have other ones there. We got daptomycin, bacitracin, polymyxin. We have other ones. I'll give you some more backstory on those, right? Or bacitracin story. Anyways, we got ribosomes. So the ribosomes, what does a ribosome do? So you have this your introduction to cell theory, because when you talk about chemotherapeutics, you have to know the cell theory and the cell phases and the mitosis and all that stuff also, right? So there's just like a little intro coming back to this stuff. You ever thought you have to know the Krebs cycle over again, right? But this doesn't involve the Krebs cycle, but does involve ATP to make proteins, right? So you make proteins. How do you make a protein? You need RNA. What else do you need? What's that?
Ribosomes will bring over the amino acids.
Yeah, ribosomes is the factory that makes proteins, right? It takes the instructions and it makes proteins out of those instructions, right? And how do you get those instructions? It's like, it's like silly putty. RNA just takes a copy of the DNA, right? So we take a copy of the DNA with RNA, right? You take a little copy, the RNA makes its way to the ribosomes, and then it makes proteins. And proteins are used for everything from toxins in the cell wall to the cell wall itself. So it's saying it inhibits cell wall synthesis technically is correct, right? Because you're inhibiting the proteins that make the cell wall itself, right? So we can inhibit ribosomes, or we can inhibit the cell wall to destroy bacteria, right? That's how antibiotics primarily work. And then we have some interesting ones that actually work on the DNA. We inhibit the DNA production, inhibit the DNA from being made, right? We fool it and we can actually deliver free radicals like a Trojan horse. So you say, hey, look at this. This is like how you make DNA, right? And you get a little present. That's nice. And they start baking cookies. It's like, what is this? It's a chocolate chips. What is this, right? It's like, those are turds. What the hell? No, so then the bacteria just dies out of embarrassment. No, it's going to be then it's going to fail, right? The DNA is not there. You don't have the DNA. You don't have the RNA to make a copy of, right? You can't. Then yes, cell walls can't be made, right? So it's all down to the cell wall, right? And you have other things like inhibit the DNA from unraveling, or inhibit the DNA from working altogether, right? So we have these three ways to fix a cell wall, to get rid of bacteria: cell wall synthesis, the ribosome, or nucleic acids, right? Deoxyribonucleic acid or ribonucleic acid, right? DNA RNA synthesis is impaired in some fashion. Okay, so we'll be talking about these antibiotics here. Any questions on how that works? All right, so the first slide is cell wall synthesis. So these are all the bacteria that know about cell wall synthesis, right? So I put it all in one slide, laboriously kind of assembled this table, color-coded it, and make it look pretty, all right? Has all the common symptoms, common side effects, because if you look at your drug guide, it has all the side effects, right? You just need to really know the big side effects that are going to be, that are very, very common, right? Because there could be some things that are like 1% of people get, or there's things that like 39% of people get. We want to know those ones that are popular. Okay, so the cell wall itself is getting damaged, right? So somehow we are interrupting the cell wall synthesis. Okay, so again, we can be bacteriostatic or bactericidal, but either one is fine, right? When you look at that's really not very important when you're reporting that or studying that, right? So if bacteria have no cell wall, are any of these antibiotics going to work? Negative. Nothing's going to work if there's no cell wall. What bacteria have no cell wall? Atypicals, right? So we have to be on an antibiotic that covers atypicals. As you notice on indications here, there's nothing that's super colorful. If you look at the next slide, there's something more colorful. So those ones cover atypicals, right? So these guys are, big category is beta-lactams. Beta-lactams have 4 different categories in it. The first one was discovered in the 30s. That was penicillin, right? And then we made cephalosporins. And there is a big fear that if you're allergic to penicillin, you might be allergic to cephalosporins. That's been disproven, but it's still a lot of intellectual questions like to ask that. So there could be cross-sensitivity, cross-reactivity if they have like a swollen, like a hive allergic response where they have like anaphylaxis, then maybe you might consider it, but it's not terribly popular. Okay, so there could be cross-sensitivity here. Where did I put it? Inactivated. I might have just took it off the table altogether. Cephalosporins here. Possible cross-sensitivity, right? So we have the beta-lactams. So we got our penicillins. They all end in cillin, right? So ox, clox, diclox, and naph. Those are the penicillins, right? Those are the 4 penicillins we use nowadays, okay? They all end in cillin, right? And they are used, and penicillins only affect gram-positives. So if someone you get the culture report back, and they're on nafcillin, but the culture says they have E. coli, right? Because they got E. coli on their skin, I guess. I don't know, right? So they got E. coli, And it's like, well, shoot, this is not going to work, right? So we need to be an antibiotic steward and make sure it lines up with the culture report, right? So penicillins only cover gram-positives. And penicillins, are, you can be allergic to penicillins. It has a high allergy index. So that's something to be cautious of. You want to be able to recognize if someone's having a penicillin allergy, right? So usually at the hospital, we can't be giving first dose antibiotics because they could have allergic reaction on you, right? So we want to make sure that the nurse is giving the first doses. Okay, what else? How does it work? It binds to the cell wall, inhibits cell wall synthesis. Well, specifically, it's binding to a penicillin binding protein, a PBP, or a peanut butter and jelly protein, right? So it's going to bind this peanut butter protein, and it's going to, once it binds that, it impairs further development of the cell wall, and therefore the bacteria dies, right? What else? Caution with any first dose, as we mentioned, right? The second beta-lactam were cephalosporins. They came out like in the 60s, and these cephalosporins all have CEF or CEPH in the name. Usually it's at the beginning, sometimes they're in the middle, like in the first generation ones, and there are 5 generations of cephalosporins. Do you have to know every single one? No. I pointed out the ones you should know. I think I didn't even write down ceftriaxone, but ceftriaxone is like the most popular one here. Ceftriaxone, right there. So ceftriaxone is a really popular one that you try on everybody. Ceftriaxone, you try on everybody to see if it'll work, because ceftriaxone covers what? Gram-positives and gram-negatives. Okay. And then the further generations you get with cephalosporins, the more coverage they get. So they start covering anaerobes. They start covering fancy things. They brew them in the lab just to cover MRSA. So like ceftaroline covers just MRSA. That's all it's good for. So if someone has a MRSA infection and you want to be special and not use Vanco, and you have $5,000 per dose to give, ceftaroline, that's the one. So they get more costly the higher you get up in generation as well for cephalosporins. Okay. So then Pseudomonas, we mentioned, was a nasty bacteria that can make people really sick. So that's something we can brew, that they've brewed. So cefepime covers anaerobes, and it covers Pseudomonas. So that's why you see everybody on cefepime usually, right? If it's not cefepime, it's what? Zosyn usually. So Zosyn covers Pseudomonas, anaerobes, gram-positives, gram-negatives. That's 4 categories. That's great, right? So what is Zosyn? Piperacillin. I thought that was a penicillin. I thought penicillins only cover gram-positives. Well, it has piperacillin, what, added to it? Tazobactam. What the heck's a tazobactam? Right? So these are engineered to bring further coverage, right? So like it was Zosyn does gram-positive, gram-negative, and Pseudomonas, and anaerobes too, which is nice, right? So what is a tazobactam or a clavulanic acid or a sulbactam or avibactam or revibactam? All these things are added to penicillins. So you have like ampicillin, right? Clavulanic acid. So you have a, what else? We have ampicillin and sulbactam. So we're like upping the game, and we're making those antibiotics like super beefy, like little mech Pacific Rim, suits, and they go out to battle, right? So that's kind of what they are doing. They are fixing the situation. The situation being that bacteria have developed resistance over time to penicillins, and so all of our penicillins, or actually all of our penicillins, cephalosporins, carbapenems, all of our beta-lactams are called beta-lactams for one reason. That's because chemistry-wise, they have a beta-lactam ring, this little square shape right here, right? Or pentad. So that little shape right there is called a beta-lactam ring. So all of our beta-lactams have that beta-lactam ring in it, and antibiotics got smart, and they start chewing on it. So if they can chew on the beta-lactam ring, then the beta-lactam is ineffective, which it is. So so here we have our bacteria, right? We give our beta-lactam medication, right? And what do the bacteria do? They produce beta-lactamase to kill the antibiotic. But little we know, we have someone up in the bleachers that's a beta-lactamase inhibitor that's going to kill the beta-lactamase, which is inactivating the beta-lactam, so that our beta-lactam can then now kill the bacteria, right? So it's like twice removed. So it's an enzyme. It's not technically an enzyme. It's a chemical that inhibits that enzyme that breaks down the antibiotic. Okay, so these guys provide greater coverage, and also they get through bacterial resistances, which is nice. Okay, so you got penicillins, and you got penicillins with a beta-lactamase inhibitor. Beta-lactamase is the enzyme that the bacterium makes, right? So what's next? We got cephalosporins we talked about. Cephalosporins are beta-lactams. And then the most heavy-duty beta-lactam we can throw at a patient are carbapenems. All right, so carbapenems are when you need extra support. They're going to ICU. They're very, very sick, septic shock, and we need to fix it right away, or we need to throw the kitchen sink literally at them, right? And basically you need a medic to do that, right? So you call medic, and you got M for meropenem, E for ertapenem, right? D for doripenem, and then the one that's very common, sorry, meropenem is the most common, but then we have imipenem. And I kind of find out that imipenem was not that great. It has metabolites that cause seizures and cause kidney failure, so we attached cilastatin to it. So that's why imipenem and cilastatin is always combined together. Okay, so meropenem is the most common one you'll see, and meropenem covers gram-positives, gram-negatives, and it covers anaerobes, and it covers Pseudomonas. That's 4 categories, right? So that's the benefit of your carbapenems. They're really heavy duty, so like why not just use Zosyn? Well, it's because they're super sick and they weren't getting better clinically, so we have to escalate antibiotics. We escalated it to a carbapenem, right? Or if they're getting better, and we can either discontinue the antibiotic or we can downregulate if we need to. Okay, so you notice this little CDI here. What's CDI stand for? C. diff infection. So all your beta-lactams have a C. diff infection risk. All right, they're third place. First place is clindamycin, which is coming up, but that's like the most common one that causes C. diff. All right, they all cause seizures to some effect as well, which is not good. Okay, so what else do they have? So seizures and C. diff infection are common between them. Okay, what else about these guys? So ceftriaxone can cause some gallbladder situations, so it's probably not great for gallbladders, but we have other cephalosporins we can throw at them for that. All right, so those are beta-lactams. Those are our bread and butter, or our bread and peanut butter for our bacterial infections, right? And then we got some other ones out there. We talked about vanco, right? Vancomycin. Vancomycin is its own category. There's nothing else like vancomycin, right? Technically, it's called a glycopeptide, but you don't have to know that because vancomycin is vancomycin, right? So vancomycin you could think of as a red van because it causes what? Red man syndrome, right? And it's van for vanco, and it just goes through, and it's like a tree hugger. It's going to go in, it's going to hug the amino acids in the cell wall and prevent it from being bulldozed over and from making the cell wall anymore. So vancomycin inhibits cell wall synthesis. That's what all these ones do, right? Vancomycin, if you give it too fast, causes what again? Causes red man syndrome or speed shock. And then what else we do? Some of the side effects, it's nephrotoxic, it's ototoxic, right? And it causes red man syndrome, and you got to put it through a central line, ideally, right? Or a large vein. So the acronym is TUNNER. So T for thrombophlebitis, we got O for ototoxic, N for nephrotoxic, and R for red man syndrome. So you got to give it slowly, and then we talked about you got to renally adjust it. So if they have kidney damage, we can adjust the dose of vancomycin. We can reduce it or increase it based on the levels. So the vancomycin levels are low, we got to increase it, right? If vancomycin levels are high, then we got to decrease the dose, right? So those are called troughs. You could get the dose at the peak, right? You give the medication, it goes up in the bloodstream, and then it goes away, right? If they have kidney failure, it doesn't go away, right? So we have to measure those vanco levels, right? And there's some other antibiotics we can measure levels for, but vancomycin is the most common one. It's usually before the 4th dose, but it's based on hospital policy, right? So it's important to avoid kidney damage and to avoid ototoxicity. We would check what? Kidney function. What else? You would check vanco levels, right? Vanco trough levels, right? And usually for most things in medicine, 10 to 20. That's usually the right answer, right? If you have to guess, 10 to 20. That's where it should be therapeutic. Okay, there's a few outliers out there like lithium and digoxin that are like less than 1.5, but otherwise most everything is 10 to 20. Okay, so that's vancomycin. And then we got daptomycin. You'd think it'd be related to vancomycin, but no relation. They don't know each other. Okay, daptomycin is unique in that it inhibits the cell wall, but it's interesting that it goes to it says, hey, I'm a ion channel, right? And it goes into the cell wall and says, I'm an ion channel. And it then opens up the cell wall, I'm an ion channel. And then it ejects all the cytoplasm of the bacteria into the periphery. So it just perforates the cell wall, right? It says, I'm an ion channel. And then daptomycin, all right, it can be used for MRSA as well, right? So it's an alternative to vancomycin in the right situation. Perforates the cell wall. It's also nephrotoxic because it has some overlaps there. And the thing about daptomycin is that it is inactivated by the lung surfactant and it doesn't cross into the CNS. So everything else is great. So vancomycin or like MRSA usually causes skin infections. So daptomycin would be great for that. Right? But if someone has a MRSA pneumonia, they should not be on daptomycin. All right, fosfomycin is used solely for UTIs. And then what else on that one? Not much. And then we got mupirocin. You've seen mupirocin at the bedside of your what kind of patient? Of your MRSA patient, right? You throw mupirocin at the nares and to destroy the MRSA and the nares, right? Because eventually it will make its way down into the lungs. And then we got polymyxin, which is it was used in the 50s a lot, and it went away, and then it came back as Neosporin. So then everybody used Neosporin, now everybody's allergic to it and shouldn't be used anymore. But either way, polymyxin is making a return because we have all these multi-drug resistant organisms, so we have to throw everything at them to kill them. So polymyxin is the one that's used for some of our MDROs, which we'll talk about.